So the expected learning outcomes, as Simon outlined, is to talk about the situations where you should and when you shouldn't prescribe, and how to convert the doses between the different benzodiazepines, and how to safely use and stop for the patients that are addicted, and the non-addictive alternatives for anxiety and sleep problems. So let's start with a scenario. Imagine there's a patient coming to see you on a Friday late afternoon, as it always is, and he recently moved into your catchment area, so you don't know him at all. You've not received all the letters from the previous GP as yet. And he claims that he was prescribed 50 milligrams of diazepam from an addiction service in the somewhere town where he lived before. And he says he took one this morning, and now he feels like he's withdrawing. And he also mentioned towards the end of your consultation that he might become suicidal if you don't give him the prescription. So if you can start the first poll, how confident do you feel with that kind of situation? Simon?
Okay. Yeah, so we're just going to launch the poll now. So the poll is on your webinar screens for audience members, and you can select the option that you feel best applies to you. How confident are you in this scenario? Scale from 1 to 8. So if you're scoring 1, you might also want to have some diazepam yourself, tongue in cheek. If you're scoring number 8, you could deal with this quite easily using one hand with your eyes closed. Again, tongue in cheek. And just give you another 5-10 seconds to vote. I think we've got almost 60% of our live audience have voted, so just give you another. You should be able to make it. It should be quite obvious how to click with your mouse and just make your selection. Okay. Okay, so we're going to end the polling and share the results.
Okay.
So,
quite a range.
Quite a range. The biggest answer is excuse me. Biggest answer is number 1. I might also need some diazepam. And the next biggest answer is well, a confidence level of 6, so not bad, but a spread all the way across. So I'll stop the share, and I'll hand back to Victor. Thank you.
Yeah, hopefully we'll come back to that scenario towards the end. So hopefully you'll feel a bit more confident with managing that kind of scenario, and I'll give you some tips, of course, as to how to go about that. And just the next poll, in that particular situation, would you prescribe? You know, the patient's demanding 50 milligrams of diazepam. Would you prescribe that? Hello, Simon, are you there? I'm not sure what happened. I think we might have lost him. Okay, perhaps I'll just continue. So moving on, the benzodiazepines, they were introduced as a really safe alternative to replace barbiturates. Previously, the barbiturates were used, and they were really dangerous. They created a lot of dependence, and they have a really narrow therapeutic window. So in overdose, they were really deadly. So benzodiazepines were obviously much safer, and they began to be prescribed in the early 1960s. And just to show how popular they have become, is that already in 1966, Rolling Stones made a song about the use of benzodiazepines in the housewives at home, and they called them Mommy's Little Helpers, hence the title of my talk. So in a space of a few years, the medication made it into a pop song, which hardly ever happens. I don't remember the last time I could hear a song about this simvastatin or anything like that. And the popularity grew, and by the 1970s, as I've outlined, they were the most prescribed medication of all time. And at the moment, obviously, the prescription rates reduced a little bit. We've realized that there's dangers related to benzodiazepines. However, we still prescribe quite a lot. So in terms of looking at the hypnotic medication, both benzodiazepines and Z drugs, the rate of that stabilized at about 10 million prescriptions a year. And fairly recently, Z drugs overcame the benzodiazepines. So there's less and less benzodiazepines prescribed for sleep, and more Z drugs, but roughly the same number if we include both of them. When it comes to the benzodiazepines used as an anxiolytic, that is creeping up actually. That's about 7 million prescriptions a year recently, and it's slowly on the rise still. And it does vary from place to place. The research shows that the lowest rates are in London, and then the highest in the north. Some would probably comment that you need something to cheer you up if you live in the. But I think it's related to a lot more complex picture of the availability of other services and the rates of deprivation. So it's quite complex. And the research also shows that the rate of non-prescribed benzodiazepine use is roughly stable. However, I don't know how they could possibly establish that, and hence the ratio of how many people can actually be addicted is huge. I mean, it's between 0.5 and 1.5 million of people in the UK that are dependent on benzodiazepines. So because it's so difficult to establish, especially the non-prescribed benzodiazepine use. And they cost roughly about £1 per 10 milligrams on the streets. It's probably a little bit cheaper if you order it from a pharmacy online. From what the patient told me, it's about 50p per tablet, especially if you buy in bulk. That is working out way cheaper. How do they work, benzodiazepines? So there wouldn't be a good psychiatric presentation without a picture of a brain. So there you go. This particular picture of a brain shows you where the GABA receptors are located, the pathways on which the benzodiazepines work. And they bind to GABA-A receptors and have all sorts of different actions just because they're located in so many different places in the brain. So they relax you, they help you go to sleep, they reduce your anxiety, they reduce your chance of having an epileptic fit, relax your muscles. And also, they lead to amnesia. In particular, it's the new memory creation that's affected. So the anterograde amnesia is present with benzodiazepine use in particular. So the indications then stem from the actions of the medication. It's used for anxiety, sleep disorders, epilepsy, alcohol withdrawal. It's also used before an operation and in intensive care. If you wanted really deep sedation, then you'd use huge doses. In psychiatry, it's used to help people that are agitated, and we're talking in particular scenarios of an inpatient admission or someone requiring home treatment team. And then the indications for the patients, or actually the substance misusers, is using it for the buzz. So you probably remember of the paradoxical reaction. That's something that happens when you take benzodiazepines, usually in a big dose, usually very quickly. So a chance of paradoxical reaction is much greater if you, let's say, inject the benzodiazepines. It's much greater if you have organic brain disorders, certain personality disorders, and you would feel the buzz. And the benzodiazepines that get to your brain really quickly, so the ones that are really lipophilic, like diazepam, they create more of the buzz just because they absorbed really quickly and then get into your bloodstream and then into your brain. And a lot of patients that I've seen, they also would use benzodiazepine towards the end of the period of stimulant use. So let's say they've been smoking crack all weekend, and they just need something to relax to be able to go back to work or whatever they need to do during the week, they would then use the benzodiazepines for that specifically. Okay. And then the benzodiazepines were really loosely classified into sedative and anxiolytic, because they all bind to the same receptors in the brain, the same location on the receptors in the brain, and they cause the same action. However, if the action only lasts for a short while, then they're used more as a sedative. And then if they stay in your system for longer, say diazepam together with its active metabolites, nordiazepam, it stays in your system for about 4 days. So they're used as the ones that are anxiolytic. But as I said, both of them work in the same time. It's just about how long they stay in your bloodstream. So the half-lives are very different to them. And the BNF, they listed under medication for anxiety, under the medication for epilepsy, and obviously temazepam for insomnia. But obviously they're used for all sorts of indications that I've described before. Something I wanted to say is the fact that benzodiazepines seem to have a bad reputation, and not surprisingly, but I wanted to highlight that benzodiazepines are really useful medication. They're really useful if they're used for a short period of time. The indications are to use them for a maximum of about 4 to 5 weeks. And there are exceptions, but for the whole, you shouldn't really be using them for more than that. And the reason for that is the tolerance to the sedative effect develops really quickly. It is about 4 weeks, and the patients no longer have the benefit of the sedation after the first initial 4 weeks. The anticonvulsant effect, that takes a little bit longer, but you can have breakthrough epileptic fits while being on benzodiazepines. The evidence on the effect on the anxiolytic sort of element of the action is a bit mixed. So some of the research says that the anxiolytic effect stays there forever, but some of the other research shows that it actually takes a little bit longer, but the tolerance develops. So after a while, the patient won't feel the relief with the anxiety any longer. And then there's no tolerance that's being developed to the problems with the memory creation. So that problem will remain there. So the maintenance therapy, even though it's not effective for the things that we want to, it still makes it really difficult for people to create new memories and affects the cognitive function. And also, there's obviously other effective treatments available for all those conditions. So we shouldn't really be using the benzodiazepines for longer than indicated, unless, of course, in the very exceptional circumstances. So, Simon, are you there? Could we have
the
next
I'm
call?
here. Yes, that would be great.
I've lost you there somewhere for a while, but
I'm here. No, I was just we had the delivery of a drum kit, and while you were talking, I just had to nip out and let them have the key to the room behind the garage, but I was literally gone for 30 seconds. Sorry about that.
I've just skipped the second poll, but
fine. So let's do the second poll.
That was a while ago. Let's just do the third poll, I suppose.
Sorry, I'm sorry. Okay. The third poll is in progress. I'm sorry about the mix-up with the second poll. Because I'm full of a virus at the moment, I wonder if it's having the effect of being a little bit dosed up on diazepam. Now, how long does it take to become dependent? So the options on your screen are 4 weeks, 4 months, 20 months, and the last option is it depends. And I'd encourage everybody who is able to have a vote. I think we've got over 80% of our audience have voted. So the last 5 seconds, and then we will share this result. Fantastic. Okay, so very interesting. We've got a split. 45% of our voters, if you can see that, Victor, 45% are saying 4 weeks to become dependent, 10% going for 4 months, no takers for 20 months, and 45% are saying it depends, which leaves a lot of room for maneuver. Okay, I'll close that poll. Thank you.
Yes, I'm a big fan of the it depends, because that's the reality. However, there is some research on that particular topic. So if we look at the primary care population, if you take benzodiazepines between 1 to 5 months, the rate of dependence is roughly about 15%. So only 15% of the people who take it between 1 and 5 months will develop actually clinically defined dependence. The average is actually 20 months, and I think no one decided on that particular option. So the average time to develop dependence on benzodiazepines in the primary care population is 20 months. If you take it for much longer, let's say more than 4 years, and I definitely see a lot of people like that, then you over 70% likely to develop dependence. But then it also depends on the dose that you take. So if you take less than 5 milligrams, it's only 1 in 5 that develops dependence. However, if you take more than 40, it's almost 90%. It's almost 9 in 10 people on that big dose will develop dependence. And then it is higher in psychiatric patients, in particular people with dependent personality disorder, and people who are just don't have those coping strategies developed other than taking their medication, and they find that it's helping them. And that's obviously significantly higher in the addict population. People who misuse, especially opiates, alcohol, there is cross-dependence, so those rates will be significantly higher. So it does depend. On average, for the patients you see, it's 20 months. And then if you continue prescribing benzodiazepines, for women that become pregnant, it unfortunately increases the risk of malformations, and especially cleft palate. And also if it's continued after women find that she's pregnant, then the newborn can be born sedated and then develop withdrawal symptoms. They don't present straight away, so quite often patients and the child would be discharged from the hospital, and then a week or even a little bit longer down the line, they would present with those really unusual symptoms of just being, crying more and sweating, and that would be the delayed withdrawal from the benzodiazepines that they took while in the mom's womb. And then another really important factor is the significantly increased risk of death from the substance misuses. So if someone's overdosing on heroin, then they're almost 3 times as likely to die if they have benzodiazepines in their system. And obviously that's, if they also drink alcohol, that risk increases even further. So if someone's continued on the maintenance prescription, these are all the risks that are present, as well as the memory problems. So now moving on to the Z drugs. I'm just going to mention them briefly because I'm sure you're well aware of that. So most of them, the name starts with a Z other than the S zopiclone. And they aren't chemically benzodiazepines, but they bind to exactly the same place that the benzodiazepines bind in the GABA-A receptor. And they have shorter half-life, so that's why they're used as the sleeping tablets, because they only stay in your system for a while, and when you wake up in the morning, you no longer feel that sedation. And because of that, because they don't stay in your system for such a long period, they're possibly less addictive. However, of course, they do the same thing, and I've seen patients who would take them not just at night, but also during the day, and use them as benzodiazepines, essentially. And then moving on to what previously were named legal highs. The name in the literature now is the newer psychoactive substances, or NPS. And it wasn't just the spice that you can smoke. It wasn't just the meow meow, the methadone. There was at least a dozen of benzodiazepine equivalents available to buy from your local head shop, to buy over the internet, completely legal. Obviously, with the recent changes to the law, they're no longer legal. But as you can imagine, there were huge stocks of these products. So then they're now being sold by the dealers, and you can buy them in the internet still, and perhaps more in the dark web rather than on illegal websites, because they can be clamped down. But they are still available, and some patients can present with them. The two biggest groups were Zolams and Z-pumps. So the name is similar to the benzodiazepines. That's how you can recognize them, if the patients know what they're actually taking. So let's move on to a second scenario, just to break it up a little bit, because I'm talking at you quite a lot. So imagine this time you know this patient really well. He's a 45-year-old HR manager who works in a huge corporation and really busy. So you know him quite well. He presented a couple of times with high blood pressure. You've managed that without medication, and it's now fine. And you know he's otherwise a decent person. And he tells you that he started buying modafinil, which is the stimulant. Provigil is the most popular brand name, because he was working long hours and he wanted to stay awake. The coffee and cigarettes were just not working for him anymore. And because of the use of the modafinil, he needed to start using Xanax, which is alprazolam. And he started from taking just 0.5 milligrams, but then found himself needing to use more and more. He used it because he wasn't able to sleep, primarily. He then started using that during the day, just because the increasing doses of modafinil that also make him quite anxious during the day. So his use escalated. And let's say you are able to confirm that he's dependent. I mean, you can see the tolerance, you can see that he wanted to stop and he encountered problems. That's why he's presenting to you. So in that particular situation, he's taking 2 milligrams of Xanax. Simon, if we can activate the next poll, what equivalent of diazepam dose would that be, the 2 milligrams of alprazolam? If we can activate the next poll, please.
Okay, good. So this poll is launched and live on the screen. So poll number 4, this patient's taking 2 milligrams of Xanax. What would be the diazepam equivalent? So we've got options of 2 milligrams, 5 milligrams, 10 milligrams, 40 milligrams, and 80 milligrams. And we've got just over 60% of our audience have voted so far. So I'll give you another 10 seconds if you've not yet made a selection, and encourage everybody who is able to cast your vote. Okay, I think we've got there. So the biggest vote group is 46% of our voters have gone for 10 milligram equivalent dose for diazepam. We've also got 31% saying 40 milligrams, 19% going for 5 milligrams, and a few going for the first option, 2 milligrams. No takers for 80 milligrams. Okay. So the biggest group, 10 milligrams.
Okay. Interesting. Thank you. Yes. If there's one thing you'll remember from this talk, I would want that to be this: there is benzodiazepine equivalence tables available, and you can find them in the BNF. And I would recommend looking at this website, benzo.org.uk. There's not just the equivalence table available, but there's a lot of other useful information. But let's have a look at how much, what the equivalent dose is. So here they comparing 10 milligrams of diazepam to some of the more popular benzodiazepines. So alprazolam, 0.5 milligram of alprazolam is equivalent to 10 milligrams of diazepam. So if he's taking 2, that's obviously 4 times as much, and 4 times 10 is 40 milligrams. So I think the most popular option was 10 milligrams. And obviously, if you prescribe that to someone that was taking what in essence is 40 milligrams of diazepam, they would experience significant withdrawal symptoms. I think the 40 was the second most popular. So congratulations to those who were able to guess it correctly. And I need to say, I even see that with some of my colleagues, they would sometimes prescribe the doses that wouldn't be the exact equivalent. So unfortunately, that's what it is. It's worth looking at those tables just to be sure that you are giving the same, the equivalent dose. And it obviously will be a little bit different for if someone has significant liver problems, but for the majority of patients, that's what would work. And I just highlighted the Zopiclone as well. So 2 tablets would be equivalent to the 10 milligrams of to 7.5 would be equivalent to 10 milligrams of diazepam. Right. So looking at the dependence, it's essentially almost the same that the dependence on alcohol. You would look at the same sort of symptoms, and you're looking at least 3 out of 6 and present in the last 12 months. It's the need to use the benzodiazepines, it's difficulty in controlling it, it's neglecting any other alternative pleasures and interests, it's using it when you recognize that it's harmful in some way. And then there's obviously the withdrawal state, which is, again, very similar to alcohol withdrawal. Perhaps the biggest difference that would be that the withdrawal has a long tail. So you would have a low-level psychological symptoms present for significantly longer than with the alcohol. But in essence, it is the same. It's sleep problems, it's gastrointestinal disturbance, it's raised anxiety, all the sort of things that you can imagine with someone withdrawing from alcohol. And then obviously evidence of tolerance highlighted by increasing doses. And ideally, you would want a serious urine drug screens performed. I know it's not always possible to do it in practice, but imagine if someone took just 1 tablet of diazepam that stays in your system for about 4 to 5 days. So even if you test it on Monday and Friday, they could still, the same tablet can produce a positive result. So ideally, you would want them done at least a sort of week apart. But I know in practice, it's not always possible. And some of the urine drug tests, they don't, some of the benzodiazepines, they don't show up. So that's another challenge. So if you decide to test it, you need to see if what the patient is describing they're taking is picked up by that particular tests that you're using. So then moving on to detoxification. The recommendation is to convert all the benzodiazepines that someone is taking. So let's say someone's taking a little bit of lorazepam during the day and maybe a bit of temazepam at night. You convert it all in the diazepam equivalent and prescribe just 1 medication ideally. And very rarely someone would need to take more than 30 milligrams. That's exceptional circumstances like someone that's been prescribed by someone else a significantly higher dose. But even in the addiction settings, we would usually really quickly reduce it down to 30 and then start slowing down with the reduction. 30 should protect everyone from having an epileptic fit, unless in exceptional circumstances they take a huge dose. And the BNF recommends reducing by about 1/8, so 12.5% every 2 weeks. What I would say is perhaps negotiate with a patient a little bit. So sometimes they might find a particular reduction a bit more difficult than the ones before. So if that's the case, if that's what they're reporting, you can prolong that particular dose for another 1 or 2 weeks. If you're increasing the risk, the chances of that detoxification being successful, then perhaps it's worth it. But then, of course, don't keep them on the same dose, even if they say they're comfortable. Make a plan and agree with the patient the plan that it will continue, the reduction will continue, and it will be stopped eventually. And then just a rule of thumb, it's in particular if someone's been taking for, let's say, 10 years, you shouldn't reduce it for less months than the years that they've been taking it. So if they've been taking that for 10 years, you shouldn't really reduce it quicker than over the period of 10 months. So it's a long game potentially, but it increases the chance of that detox being successful. And then moving on to the alternatives for anxiety. I mean, I'm not going to go into too much detail on that. I think recently one of my colleagues presented a talk on that particular topics, but just in case you've not heard that talk. So for the sort of lower level end of the spectrum, just mild symptoms, guided self-help and lifestyle changes are really effective. So lifestyle changes, I'm talking about the things like breathing exercises, increasing your physical activity during the day, reducing the caffeine intake, in particular, in the evenings, that prevents people from sleeping. And then obviously there's a range of psychological treatments for the particular anxiety disorders, and they are very effective. In some cases, perhaps even more effective than medication. Of course, antidepressants are the main psychopharmacological treatment for that, and it's accessorized for the majority of anxiety disorders. Pregabalin, two things about pregabalin. There is increasing reports of people abusing pregabalin, but it wouldn't stop me from prescribing it for someone that didn't respond to antidepressants. It's still a useful medication, and it doesn't really create dependence in the same way that the benzodiazepines can. It's more the potential for abuse rather than the risk of dependence, which is still there, especially psychological dependence, but it's nowhere near to the extent that we see with the benzodiazepines. Okay, of course, the future can prove me wrong on that. Something that I tend to use, in particular for patients that need something as and when, instead of benzodiazepines, would be promethazine. It's a sedative antihistamine, and quite often that's really useful. It's really good because it doesn't create dependence. You can use it either regularly or as and when required, and even in overdose, it's really safer. It's probably even safer than paracetamol in overdose. So I tend to use it quite a lot. And then I know that GPs tend to use beta blockers, propranolol, quite frequently. What I would say about propranolol and beta blockers in anxiety is that if patients experience really intense physical symptoms, then yes, it can be useful. But in some way, it's similar to benzodiazepine. It's masking the symptoms. It's not allowing the person to try and learn the coping strategies for the anxiety. So it's a double-edged sword. It's helpful in the short term, but when you win people off, it needs to be done gradually as well. And it doesn't help in people overcoming and learning how to manage their anxiety. So in that way, it's not useful. But symptomatically, it does help. I appreciate that. Now, looking at the alternatives for insomnia, I'm going to mention some obvious things, but if there's an underlying cause for the sleeping problems, then depression, mania, so both mental health and physical health problems, if they treated, that can improve things. It's worth asking yourself, and perhaps the patient as well, whether there's any problems with abusing any substances. That might not be obvious initially, but it's worth having that discussion. And something I surprisingly often still see is that even though we make recommendations about antidepressants and some sedative medication that we use, patients don't always take them at the same time as we recommend that. So I often find that people complain of sleeping problems, and then when you ask them a little bit more, they take the fluoxetine, which is quite an activating antidepressant. They would take that at night, and of course it is really likely to disturb their sleep. So it's worth just double checking that patients take the stimulants in the morning and any sedative medication at night, unless it's recommended, of course, to take twice a day. But that's something worth checking, definitely. And something I try to give to as many patients as possible is just a piece of paper. It's a piece of paper with sleep hygiene recommendations. And it's something that's easy, well, I suppose that's simple, but not always easy. doing things like increasing on physical activity during the day, stopping the naps at night, during the day, and sleeping just at night, reducing the caffeine intake, especially in the evening, reducing alcohol. Alcohol helps people get off to sleep, but what it does is it reduces the quality of your sleep. So you're much more likely to wake up at night, and you won't feel as refreshed in the morning, just because it just changes the composition of your sleep. People obviously should use bed for sleep and perhaps sex, not any other activities, because they need to associate that in their brains with sleeping. And using relaxation and breathing and mindfulness exercises, it's really helpful. Obviously, like with every exercise, the more you practice, the better you get at it. And but if you're recommending that, people shouldn't feel that they're gonna benefit from that initially, really quickly. And another thing, just to keep regular routine. So going to bed at the same time and waking up at the same time, even at weekends, even if there's nothing to be done, just making sure that your body gets used to a particular pattern of sleeping. And in the 21st century, as we're doing now, we're exposed to a lot of screen time. And it keeps us awake, unfortunately. And it's not just being excited about what happened in the last episode of Game of Thrones. It's also just the biological things. It's the blue light that's emitted in most of the devices. It reduces the amount of melatonin that your brain is producing. So naturally, it will keep you awake. And the technology is adapting. I've seen some of the recently coming laptops. They actually have a mode where you can reduce the blue light emissions so that they don't affect your sleep as much, which I think it's worth looking for if someone obviously suffers with the sleep and they still need to work late nights, like perhaps myself and you sometimes. Sorry about that. And obviously there's other medication that are non-addictive, like melatonin and Ramaton. That's something I've not seen that in the UK. It's something that's quite popular in the States. That medication acts on the melatonin receptor, so essentially almost the same as melatonin. And the research shows that it should be quite effective, but I don't know why there's a delay in introducing it to the market in the UK. And of course, some of the other things off-label. Promethazine, again, non-addictive, take it or leave it. GPs prescribe quite a lot of amitriptyline, and pros and cons again. Some patients can have quite a lot of side effects from amitriptyline, and so it's worth asking them whether it's helping more than it's doing any harm. And one thing that I perhaps don't like about prescription of amitriptyline is if someone is on a different antidepressant already, let's say on an SSRI, prescribing the different class of antidepressants can ever so slightly increase your risk of developing serotonergic syndrome. So it's not a great risk, but that's just something to consider when you're prescribing amitriptyline on top of other antidepressants. But it is useful, and most people don't have significant problems with that. And if there's any pain that's stopping people from sleeping, obviously it is useful. A low dose of antipsychotics, similarly, it can be used if you see, especially if someone has, let's say, depression with psychotic symptoms, or just for insomnia, if you tried all the other things that they were not effective. So just worth thinking about the balance, risk and benefits between the side effects of antipsychotics. But at the low dose, of course, they would have less problems. Right, we're almost there. So going back to the initial scenario, you've got the patient that you don't know. He claims to have been prescribed 50 milligrams of diazepam from somewhere town. And he says he's withdrawing, even though he took his last tablet this morning, and he might become suicidal if you don't give him the prescription. How confident are you with this now? I hope a little bit more than previously.
Okay, so we will launch this poll. Okay, so the poll is live. How confident are you with this scenario? From 1 to 8. Okay, so good. Another 10 seconds if you haven't yet voted. I encourage you to cast a vote now. Okay, last few seconds, now or never. Okay, so we'll just share the results. So we've got quite a split. The biggest option would be option 6, a confidence score of 6, 21% of our voters. 11% were a little more than confident in that. 18% scoring 4, 18% scoring 5, and so we've got a nice sort of bell-shaped curve.
Yeah, I think it's moving in the right direction as well. So
definitely.
Just a few tips, perhaps. So in that particular case, as I said, it's really unlikely that he would be prescribed more than 30 milligrams, unless you can confirm that. Let's say he knows the name of the pharmacy that was providing him that medication, and you can call them and confirm that, yes, he's been given 50 and the last time he picked up was a week ago. Unless you can confirm that, I wouldn't go nowhere near that dose. And as I said, diazepam stays in your system for up to 4 days if you include the active metabolites. So it's really highly unlikely that someone's withdrawing, or almost impossible that someone's withdrawing if they took a tablet in the morning. What they could be referring to is perhaps they don't feel the buzz, they don't feel the other effects, but they wouldn't be withdrawing at that stage. And if someone is threatening that they might become suicidal, that's what it is essentially. That's a threat. That means that they don't feel suicidal when they talk to you. They just might. And what I would suggest doing in that case is to, depending on your local arrangements, but usually there's some sort of crisis number that you can give them that they can call, or be it Samaritans or your local mental health trust, and give them the details of the nearest accidents and emergency where they can attend if they do become indeed suicidal. I know it's easy for me to say, and sometimes doctors would give in, just being afraid of the patient's actually going to do something. But if they threaten that they will become suicidal, that means they aren't at the moment, and that's a threat wanting to obtain something from you. Hope that helps for that to be a bit clearer in your mind. So I'm here because I'm representing Psychiatry UK, which is an online private psychiatric service. And at the moment, we've got about 30 consultant psychiatrists covering a range of specialties, from general adult psychiatry for child and adolescents, older adults. I'm working on developing the addiction service, the specialist in ADHD and adult ADHD, and also in sleep disorders treatment. So if you think that someone would be benefit, perhaps the patients that find it difficult to travel, or anyone that prefers that relationship rather than attending your local mental health service, then please consider that. Thank you. Any questions? Feel free, I'm all yours.
So many thanks indeed, Victor. You can pause and have a drink, of a soft drink. So questions. We have got some questions. So just going back to that scenario, Friday 5 p.m. and this patient that you've not met before is asking for 50 milligrams, and quite rightly, as you say, you're wondering what his agenda is really if he's saying he's now withdrawing so soon. What dose? You said you wouldn't give him anywhere near 50. Yeah. Would you give him 30, or where would you actually, put your stake in the ground?
Yeah. I mean, as I said, I'm really big fan of the "it depends" answer, and it depends on a number of things. It's worth finding out whether he's also drinking alcohol and how he's managing that in the interim, whether he's using any other substances. If you can really call the surgery or perhaps even the addiction service, they might sometimes be open on Friday for a little bit longer. If you're able to call them and confirm, that would give you much more confidence in that prescription. So it really depends. Looking at the patient, if they appear like they've just taken loads of heroin, then obviously I would be really careful in prescribing. So I'm talking small pupils and the typical signs. So there's no ideal answer. I mean, 30 milligrams should stop them from withdrawing, should stop them from having any significant issues if you are willing to prescribe. But think about it. And ideally, the addiction service should have contacted either yourself or your local addiction service. It's highly unlikely that it just would be left like that. So really high I would have really high threshold to prescribing in that particular case. But then it depends what's available locally and all those things.
So I seem to remember from years before when we've had training, people would say, oh, well, you need to explain to the patient they can't just walk in and expect a prescription, because you need to do a proper assessment, you need to urine drug screen, and that's, so you're sort of explaining. I can remember it's happened to me a lot over the years. You're explaining why you're reluctant to give them anything, and then they start ratcheting up the threats, and patients come. It can be very difficult. There can be feel like you're being either threatened or manipulated. Very, very difficult. So I'm glad that you sort of said that it's it's not easy. Let's see.
Perhaps something I would add here is, if someone's taking street diazepam and they're not willing to reduce the dose, then I wouldn't go nowhere near prescribing them anything. If they are obtaining it illicitly, then you can just recommend a reducing regimen that they can implement themselves and keep obtaining it from the usual supply source, rather than you introducing additional supply into the black market, essentially. So I know that more and more addiction services are only dealing with alcohol and opiates. I'm sure that the colleagues will see more and more of cases like that. And it's worth thinking about that if someone's able to obtain it, then would you want to add it? More increasing the risk of overdose and all those things I've mentioned.
So I guess the theme would be to avoid knee-jerk prescribing, and
it's more possible, and avoid long-term maintenance prescribing, because it does more harm than good.
And you might end up prescribing you may end up prescribing a small amount of diazepam over the weekend, but presumably it's Friday, it's 5 o'clock, you're going to want to get the patient back and do a more detailed assessment. And if they're actually motivated, I guess that they're more likely to cooperate. And you talked about the importance of a plan. How often do you always insist on having a plan when you're seeing patients and prescribing?
Yes, definitely a reduction plan, and it should be really closely followed. I mean, there is periods when they can find it really difficult, something happened in their life, but patients find giving up diazepam more difficult than giving up heroin. I was surprised when I first heard that, but that's the reality. It just puts people into this really comfortable psychological place where they don't worry about anything essentially, and they don't remember about the new problems that they have because that affects their memory. So they find giving it up really difficult sometimes. That's why the plan of reduction is really important. And you agree it with a patient, and then you say, listen, that's what we've agreed, and let's continue.
Okay, fantastic. Now, so a colleague's asking, would there be any particular physical signs you'd look for before reaching the decision of prescribing them diazepam if you're concerned that they're withdrawing?
So as I've mentioned, that would essentially be the same things you'd be looking out for in someone that's withdrawing from alcohol. So sweating, tremulous, really nervous, gastrointestinal disturbance. There's no other particular things unless they start having an epileptic fit. But essentially, that's the same that you would have in the alcohol withdrawal. The biggest difference, I suppose, is that it can often last much longer, especially, as I said, the tail end of the withdrawal. It can last for months. And again, the rule is that depending on how many years they've taken, that they can have those low-level withdrawal symptoms for roughly as many months as the years they've previously been using. So they just might need maybe something to help them with their sleep, something else with the anxiety. This will be, again, at low level, but a similar sort of range of symptoms that you would have when someone's withdrawing from alcohol.
Okay, fantastic. So thank you for that, Victor. Just a quick one to sort of so that we can cover it and dismiss it. Talil is asking about use of diazepam as a muscle relaxant in an orthopedic setting if somebody's got back pain and spasm. Yeah, I mean, that's not really the subject of tonight, yeah. But do you have any comment on that, Victor?
I'm not sure how long it takes for the muscle relaxant tolerance to the muscle relaxant's effect. I'm not entirely sure. I would think it also reduces over time, but I'm not an expert in that. So
yeah, the understanding I've had just for Talil is typically if somebody's having spasms, you only need to use something like diazepam for the spasms for up to 24 hours. So you're talking, 3 or 4 doses, and that's it. But you might be using 5 milligrams 3 times a day, but literally only 3 or 4 doses, and then that acute phase has passed. If anybody has got a different view on that, they can type in. So we've got quite a lot of questions here, so let's see if we can get through some. So Mark's asking, relating to insomnia, after expanding the sort of talking about sleep hygiene options, sedative antihistamines, he sometimes prescribes 7 to 14 tablets of Zopiclone over a 1-month period and says to the patient that they have to make that last the month. And he's asking, is this a credible option, and will this adequately minimize a patient's risk of becoming dependent?
Unless you've got reasons to believe that they are abusing it, then it's a good strategy. Perhaps, using it every other day or less. It greatly reduces the chance of them developing dependence on that. It's much better than using it like a low dose every day, which doesn't really help with the sleep and makes it perhaps more likely to develop problems like that. But if it's a few tablets over a month, that's quite a useful option if you really try it on the other ones and it didn't work. Yeah, it greatly reduces the risk of dependence if it's this way. When people abuse the drugs like Zopiclone, they would use at least 4 times the prescribed dose, so it wouldn't last them for too long. So again, that's I think a good strategy. Of course, if you've tried all the other things and they didn't seem to be working.
Okay, thank you. And a query about the dose of pregabalin. You mentioned pregabalin. Now, was that for anxiety? I'm just trying to look at my notes.
Yeah, it was one of the options after you've tried antidepressants, then you can try anxiety. I mean, the starting dose would be 50 milligrams 3 times a day, and you can slowly, well, relatively quickly increase that depending on the response and side effects. Most of the people tolerate it pretty well, and they find it's helping them pretty quickly. So the maximum dose then would be 600 milligrams in a day. So usually you split that into 3 times a day. Yes, the starting dose would be 50. Most people find average doses helpful. Some people towards the end, they might experience similar symptoms to having too high dose of benzodiazepines. So it might be slurring their speech. They might be a bit disinhibited. So just be mindful that it can have some similar sort of effects. It can also increase suicidal thoughts. Pretty rare, but obviously something to watch out for as well.
Okay. Thank you. When you were talking about alternatives for sleep rather than the Z drugs, you mentioned maybe low-dose antipsychotics, is there a particular one or two that you would go for first of antipsychotics?
Well, obviously you need to look at the patient's physical health and all the other aspects and take that into consideration. The ones that are the most sedative would be things like olanzapine, quetiapine. This would be probably the most helpful. But of course, if someone's diabetic, then try and stay away from the olanzapine and just looking at all the other sort of physical health aspects. If there's sort of problems with high cholesterol, symptoms like that, then I would stay away from the antipsychotics.
Okay. But low doses, we're talking lower than you normally would use.
We're talking 25 perhaps of quetiapine, olanzapine 2.5, that sort of doses. And the response is better than the possible side effects that they get.
Fantastic, thank you. Ronnie's asking, how should we attempt to treat addiction of etizolam-based NPS drugs?
Essentially the same. You convert the dose into the equivalent diazepam dose, and you plan a withdrawal regimen with the patient. It acts as essentially the same. Just because it's a newer psychoactive substance, it binds to the same receptor in the same place, just like any other benzodiazepine. So just look up the equivalent doses online.
So the benzo.org.uk would list etizolam.
I'm pretty confident it would. If not, there's other sources online that would be more exclusive. But I think etizolam was fairly popular with some of the US, so it should have been included in that analysis.
Great stuff. And just colleagues are keen for doses. The off-label dose of promethazine that you'd use for sleep, if you were going to use it? 25
to 50. Patients can try 25. If that doesn't work, try 50.
Okay.
In patients, we sometimes use up to 100 a day. The official BNF recommendation is to use 50. I probably wouldn't go higher than that.
Okay, fantastic. And on the subject of Z drugs, Saibal is saying, I'm trying to persuade some long-term Z drug users to try melatonin rather than going to the extent of weaning them onto diazepam, especially when their cooperation might not be readily apparent. What do you think of this approach?
Well, it depends. The things it would depend on is how long they've been taking that. Have the doses escalated over time? Because perhaps you might need to reduce it slightly before you go on to melatonin. Otherwise, they will have the rebound insomnia that will be difficult to treat with just melatonin. So it will be different for someone that's taking 15 milligrams every day for the last 6 years and someone that's taking 3.75 every other day. The approaches will be a little bit different. In the second scenario, you could perhaps try and go straight onto melatonin. In the first, you would need to reduce it slightly, either the zopiclone itself or converting it into diazepam and then reducing. Yeah.
Fantastic. And on the subject of antidepressants for anxiety disorders, do you have a particular antidepressant that you like to use as your first go-to antidepressant? Ronnie's asking which might be the better one for anxiety.
Yeah, I mean, as my colleague Chichi sort of recommended in the recent talk on the anxiety, there isn't a great evidence in one being better than the other. But we usually recommend SSRIs for most of the anxiety disorders to start with, and then what I would look at as to which one to start is at looking at the physical health and if there's any other sort of things that we need to look at. So looking at the side effect profile rather than one being more effective than the other. And perhaps some tips, fluoxetine is better if someone's got diabetes. It's proven to actually even improve people's HbA1c. It's also helpful in people if they need to lose weight. Sertraline has the best evidence if someone had a heart attack and after an MI. That's the drug of choice. And there's obviously there's other minor sort of differences, but that would probably be the main things. And citalopram is often indicated as the first choice, just because he has very little potential interactions with other drugs. We can't, we're not allowed to use the dose up to 60 milligrams as we are allowed to use before. So that reduces that sort of level of dosing that you can use. It used to be better, but of course, it's still a useful first medication to try, especially if someone's on plenty of other medication already. So just those tips. SSRIs in general, but then you would choose one depending on some of the other physical health, I suppose, main.
Fantastic. Thank you. Now, you mentioned the online website, benzo.org.uk. Bakula's asking, is that a website that's facing towards patients as well as clinicians?
I think it is. It's available to anyone, yes. But the resources are, it's not just a random collection of someone's thoughts. It's research and evidence, most of it at least.
Yeah.
It's available in the BNF, of course, but I think the BNF took the equivalence tables from Ashton Manual, which is available on the benzo.org.uk.
Great stuff. Now, promethazine. Was promethazine mentioned for sleep as well as anxiety? I think. That's
right, yeah.
And was the dose different if somebody has anxiety as the main issue rather than sleep?
I mean, where I would use it for anxiety is perhaps, again, the lower level sort of anxiety, and in particular, if it's fluctuating in nature. So perhaps not panic attacks, but if someone's anxiety goes up and down a little bit and they would want something to just reduce it a notch when they need to, then that's when the promethazine is particularly useful, if they find it effective. It can be taken regularly as well, but then again, it's you need to see if it works for the patient, essentially.
Okay, great stuff. And Olalekan is making a good, interesting point. Is it true? Do you agree with the statement that most of the street or online benzodiazepines are fake or diluted down, and so the dose conversion, if we're going to start prescribing, could be there could be some issues?
Surprisingly, from what I understand, it's not. In comparison to the other illicit drugs that are available, the quality of the diazepam is usually a little bit better. I mean, of course, you can't predict what it is, but diazepam is more often diazepam than, let's say, cocaine is actual cocaine. It's probably a little bit better, but you need to be careful, of course, with those dose conversions, and it's impossible to predict them unless you do a analysis of the substance that the patient's taking. Surprisingly better. So yeah, it being what it is, because patients or the clients they essentially recognize if it is the same thing. Some of the funny things that patients say, that if they are given 5 milligram diazepam tablets, the market value is much less, just because people want the 10s, the ones, the blue ones is what people are after. And yeah, it's a black market, but it's regulated in a strange way, so it's surprisingly better than.
Okay, so because Roger put a point in the chat, so are you saying it is likely that 10 milligrams of street diazepam actually is pretty close to 10 milligrams of diazepam?
All I'm saying that it's much more likely to be that the quality of that is more consistent than the quality of other illicit drugs, which the potency can vary much more.
Great stuff.
But if you're buying it from a street corner, and it can be anything. Okay,
great. And let's see, withdrawal now. Question about withdrawal and the risks of withdrawal from Jakob. Jakob is asking, is withdrawal from benzodiazepines as dangerous as alcohol withdrawal?
Yeah, I think I know that, Jakob. I think we've studied in the same university, by the way. So.
Okay.
The evidence on that is it probably isn't as dangerous as alcohol withdrawal. However, of course, that depends on how quickly people would withdraw, and also, I suppose, on the doses that they're stopping from. So these are the things that you need to consider. Overall, it's probably not as likely as alcohol. If someone's like proper dependency on alcohol and stop, it's probably less likely to give you severe things like, experiences like delirium tremens and the like. But then, of course, it depends on the physical health, on the dose that they're taking, on how quickly they've stopped, and what was the drug that they were dependent on. All these factors would have a play in there.
Okay, fantastic. Now, just a quick one about Psychiatry UK. Colleague is asking, can patients directly access a psychiatrist themselves, or do they need referring?
No, patients can just request on the website or on our social media. You can request a visit, and you don't need a referral.
Excellent. And it's location independent because it's online.
That's right.
So now, flight anxiety and people using benzodiazepines for flight anxiety. Any safety issues that or concerns or advice that you'd want to give people, particularly?
It's useful. If it's a small dose and someone's flying infrequently, then yeah, perhaps that's something to consider. Ideally, you would want to try psychological approaches, but if that's not something that the patients can access, or they're really reluctant, then yeah, it can be useful. And again, just wanted to highlight, benzodiazepines are really good if they're used for a short period of time. If someone's, on the other hand, a businessman that's flying twice a week, and you would want to give him diazepam for every flight that he makes, that's probably not a helpful strategy. You can also actually try promethazine for the indication. It's even over the counter available as Phenergan. So pros and cons. It can be useful if someone's really finding it difficult. They might become maybe not properly dependent, but they'll just see it as a way out. So if then they start asking you for prescription for other stressful situation in their lives, then it's the red lights that should be switched on.
And you obviously you can have unpredictable effects if they're mixing that with alcohol on the flight, if they've taken the tablet and then have a drink. That's
right. It would be, you're possibly more likely to have a paradoxical reaction as well. It's less likely with a small dose, but there is the risk of that. And you can't predict really whether they're going to drink on top of the diazepam.
Yeah, fantastic. Colleagues have typed in Northamptonshire, we've got CRI, I think the local brand name is substance to solution, and patients can self-refer, or we can, you know, direct patients or refer patients. But you're right in the sense that they have a filtering because of workload and resource issues. Depending on you've got to have a certain level of problems in your life for them to be able to see you, I think. But I'd be interested to know whether other colleagues have still got substance misuse services locally in their areas. I think the last, just while people ponder that, the last question Rebecca's asked, so if a patient's been on Zopiclone for several years, would you still convert them to diazepam if you're trying to get them off and wean them down on Zopiclone?
Well, it would depend. There's potentially two strategies that you can employ. It's either converting it into diazepam, and it's particular if you think that they might be using that during the day as well, and the dose is escalated. That's the type of scenario when I would convert it into diazepam. If you know that they're only using it for sleep and on night, and they don't take more than what you're just prescribing, then what you can do is perhaps to start reducing it 3.75 every other day, 7.5 every other day, and then sort of gradually reducing it like that. It depends on you know, whether you think they've developed a benzodiazepine-like dependency on the anxiolytic effect, or whether they're just purely using it to treat their insomnia and they're sort of insomnia dependent. Both strategies can be used. You know, just sometimes one is better than the other.
Okay, fantastic. Now, just bear with me. With the last question, nitrazepam. I didn't see that on the list. A colleague's asking, would you direct them to benzo.org.uk if they're looking for about nitrazepam addiction?
Yes. Yeah, I've only pulled up the most popular drugs that are used most frequently, but yeah, there's much more available on the benzo.org.uk website.
Fantastic. So I think we're almost at the end. Could I just ask for some final words summing up that you'd like to share with the audience? Victor, thank you.
From myself now, all I can say is thank you for joining me, as I said, on the Tuesday evening. It's good to see that people are interested, and I hope you've been able to find some of this information useful, and you can use it in your clinics from tomorrow. Yeah, that's all I wanted to say. Thank you.
Many thanks. And just for those colleagues who would like to get their CPD certificate, I'll just share the survey link in the chat. I used to do this on the other platform, so why not do it here? There we go. Okay, so the survey link I've just shared in the chat, it will also should pop up in your browser after the webinar when we close the webinar. Let's see. I'm just going to make sure that does happen. Okay, so when the webinar ends, you ought to be redirected automatically to the survey page. We'll see if that works. I'd just like to thank you, Victor, for a fantastic presentation. We covered a lot of ground there, not just long-term users, but managing short-term users. I'm quite reassured by what you said about the 4 months, 1 to 5 months, 15% can become dependent. One of the issues we have is, I think in the BNF it talks about, you know, the license is very short. I think it's, you know, a couple of weeks, isn't it? So yeah. I think that's why GPs, we're very anxious about using it.
Yeah, they're referring obviously to how long it takes for the tolerance to develop, and yeah, especially for the sedative effect. it's only 4 weeks. It's not going to be working after that period of time. So
Yeah.
is it worth prescribing something that's no longer helping and can create dependence and create other problems? That's all what they're saying, I think. But yeah, to develop dependence, you usually need much longer.
I've also shared a link for the handout if people would like to download a copy of the study guide. I've just shared it in the chat. So again, you can click that link and go and download a copy of these slides for your own reflection and help you write your notes. Once you've filled in the online survey, you will be redirected to the certificate download page. That's for people attending live. And if you're a webinars for GP subscriber, then the recording will be in the members site and you can watch that at your leisure. Thank you so much, Victor. That was really, really well done indeed. Thank you everybody that took part in the poll questions. Apologies that I was out handing over a key when you were trying to launch session 2. If I didn't go and do it then, our border collie was getting more and more uptight and agitated, and I just had to go and do it. So I'm sorry about that little hiccup, but hopefully people have got good value from the session. And please do fill in the survey. Leave your comments for our speaker, because we value your feedback. It's very useful for us, very useful for the speakers. We collate your feedback over a 2-week period for those, not just those watching live, but also watching the replay, and we share that with the speaker. That's really valuable feedback for our speakers. So I'd encourage everybody to please complete the survey. The link for the survey and the handout will come out in an email tomorrow for those who have attended live. I'll just pause the recording. So Victor, I'll give you a quick debrief ring in about 10-15 minutes, if that's okay.
Yeah.
Is that all right? And thank you everybody who took part tonight, and hope to see you all on a webinar again soon. And Psychiatry UK is a website you can check out, and also benzo.org.uk, as well as webinarsforgps.com. Okay, take care everybody, and wish you all a very good rest of your evening. Bye for now.
Thank you.
Bye-bye.